Thank you, Mr. Priya, and a good afternoon, everybody. So today we are going to have a very important session, which we usually don't learn during our medical schools or specialty or super specialty learning programs. But it is very important that we should communicate properly with patients and caregivers, which is in a way it is for our benefit than that of patient. But it is also true that there are many benefits if we properly communicate to the patients, caregivers, as well as for the healthcare professionals. So today, the faculty is Dr. Parampreet. He is a neurologist, and he is in charge of a comprehensive epilepsy program and professor of neurology at the postgraduate Institute of Medical Education and Research at Chandigarh. And he is also the chairman of Indian Epilepsy Association, Punjab chapter, and is an executive member in Indian Epilepsy Society. And he is also a life member of Neurological Society of India as well as Indian Academy of Neurology. And he has a special interest in communication in healthcare. So welcome, Dr. Parampreet, and it's over to you.
Thank you, Sunil. Thank you, Supriya, Echo, Helium India. I'm happy to be back taking this very interesting and actually very relevant session during this course. I'll just share my presentation so that you can check if everything is visible. So is it on?
Yeah.
Great. So welcome everyone, all the participants, and as already told here, this is one of the most interesting sessions we do and during this course. Everything is important. For me, it is because, as you've seen, I'm a neurologist with interest in communication in healthcare, which I keep doing sessions for various societies, scientific societies all over the country, and including our neurology societies. I'm not a palliative care physician, so I may not know the technical answers if we have any, but we can always have other people help out. So today, what the objectives for discussion today would be, what is the need for medical communication? Why do we lay stress on it? We are all very good talkers, and and what are the barriers, the usual barriers to effective communication? What are the steps to get effective communication? And that is remove the barriers and then develop skills in listening, rapport building, paraphrasing, reframing where required to make things easier for our patients and their families, and most importantly, communicating with empathy. Sunil, Sripriya, I just want to know if they have any doubts. How is it going? Are they going to open the mic and talk, or are they going to put it in the chat box?
Because they can do both.
Okay, so if you want to talk, you can raise your hand, and if you want to put in the chat box, then somebody will have to tell me, because I'm not able to see the chat box.
Yeah.
Moderator today, right? So if you have anything, you can either put in chat box or even stop and point out verbally. So does anyone want to give 1 or 2 points about what is the benefits of good communication, especially in medical features? You can just jot it down or say it out loud. Let me see if I can if I'm able to get the chat on my, So what are the benefits of, why do we need to take good to take decisions? That is good. Yeah, the patient's in a better position to take decisions. We can extract better history, better the rapport, better history we take, gain patients trust, better satisfaction. Very good, very important. Yeah, these are actually very critical points which you all are putting it down there. And, that increases the patient's confidence also. Yeah, and prevent mishaps, or yeah, I mean, what you can call them, wrong decisions when the patient is confused and anxious. I mean, absolutely on the spot. And of course, then enable self-care of our own health personnel is also very important. So that is what we actually do in this session. Thank you very much for that. Uh, Coming back to this now, I want to, if anyone wants to put down, do you think communication skills are a learnable skill, or they come naturally? And in the meantime, you can even think of any specific topics. Its communication is a very big thing. We'll try to do it in these two sessions, today and Friday. But when we do, it's a whole day course or a half day course. So anything left out, if you have at the end of the talk, feel free to discuss. In the meantime, any think about
Yeah,
learnable.
there are,
Yeah.
learned skill. Yeah.
So both learnable and both natural. Okay, yeah, that's a fair answer. I mean, there is no right or wrong answer in that. Everyone has their own view. Both art and science. Yeah, that's a good answer. What I personally think is it's both. Normally, what people believe, when we are not, when I was not exposed to this formal training in communication, I thought I was a good communicator. I take these epilepsy lectures all over and with many people attending. But so it does. There is sometimes some things which come naturally to people. Some people do communicate better than the others, but there's a lot which you can actively learn, which I didn't know. And I'll tell you the points when we come to them, that these are something which don't come to you unless somebody tells you. So it is both in that manner. So I've made this small kind of acronym or mnemonic, you can say, my 4 or 5 C's of good communication. So one is candidness. Candidness means that you have to be honest while communicating. We can twist the style. That is all the communication. Good communication is all about. That we don't give whether it's giving bad news or whether it is discussing something very serious. We try to make it more palatable by twisting the style, but we do not twist the facts. So that is very important, and we will come to that later in the talk. So it is twist the style, not the facts. The third is clear. It has to be clear. That is where sometimes all we healthcare professionals lack, is that we are busy and we thought. I don't know, someone said the very nice thing about that. The biggest problem with communication is the belief that it has already taken place. I don't know who it is. I'm sorry, I can't remember. So we feel we have already told, and the other person doesn't understand. Communication is not only about medical thing. Every day we communicate among our families, children, friends, professionally, interprofessional, spouses, and good communication helps everywhere. In patient case, we need to talk. So we have a tendency to talk medical language. You have myocardial infarction, you have respiratory failure. So those things overwhelm the people. We have to tell them in their own language. Try to make it as simple as possible. The other is concise, of course, because the patient is anxious and they don't know any medicine. We are there every day, but they are there for the first time, and we have to be very brief, at least in the first meeting. There is nothing stopping us having multiple meetings to discuss the problem. But in the first meeting, we have to avoid information overload. And the three is complete. That again, as I said, that we feel we have said half the things and half we take for granted that are gone, but they sometimes don't, and that can have consequences. This is a bit of a funny video which I keep playing. So because complete communication, this is one of the those motivational sessions with confidence building, and this guy in the green is a new person who's joined the group and they want to build this trust. So this, you can just see that hands on the side. This person explains that, how do we build trust? You get up on the stool and people will come around you, and you close your eyes, and then you fall and they will catch you. And he has to trust them that they will catch you. And so he's asked to fall, and that's what he does. He falls. But unfortunately, what the person forgot to tell was which side to fall on. So the little bit of communication which was missed actually could lead to negative consequences. Were you able to see the video?
Yeah.
Okay.
There was no voice.
No, there was no sound in this.
Yeah.
There will be sound in this. I hope you get the sound in the next one. That is important, to listen to the dialogue. So, it is not only that we just keep talking because we like talking about communication. People have done research and shown that the patients dealt with empathy showed better control in the diseases like blood pressure, blood sugar, better pain scores for sure. Because a lot of pain is emotional, and unnecessary tests are avoided, unnecessary referrals are avoided, as one of you mentioned, and better understanding of the treatment by the patient. One of the most common causes why patients default or stop treatment is they don't really understand why they are taking. I mean, in my case, I see a lot of epilepsy, and there is 1 or 2 seizures, and they have to take drug lifelong. They don't understand unless I explain to them that what is the need for taking drugs for 10 years or 5 years or 3 years once they've just had 1 seizure and they're feeling absolutely normal. Once you explain to them properly, they will adhere to the treatment and the outcomes will be better. And then, of course, they will take interest in their own planning, as again someone noted in the chat box, and will come to shared decision making. It has even become more important because for the medical legal aspects and the current this atmosphere where people can sue medical practitioners, and a thought is that a lot of these are due to incomplete communication. So if good communication took place in the first place and all the things were explained properly, the people would not be so unhappy as to go and complain or sue or whatever. So that is where it helps also. Ultimately increases patient safety. Anyone, any comments before I go to the next module? Someone's mentioned, I can see one, Mercy, calm. Yeah, very important. Calmness is important. Thank you, Revati, for that. So you can think of your comments. In the meantime, I'll carry on with the barriers to communication. So there are, what are the challenges faced by patients? Sometimes, it's not only patients, even other people, sometimes we are a little timid by nature. And in our culture, the difference between, if you work abroad, you realize how much is the difference because we have a lot of hierarchical kind of a thing. The power difference between the patient and the doctor or even any other healthcare professional is quite a bit. So people are a little scared of their doctor and saying extra words to them. So that can be a big barrier. Then they must be saying the doctor is so busy. I mean, they are taking rounds, the nurse is giving medications. I should not interrupt. They will not talk about non-medical problems, but they form a big chunk of their, their torment. They are tormented by many other things apart from the actual physical problems. And then there can be actual diseases which affect communication, physically because of movement or speech issues or something. More challenges are patients are in fear. They are in the hospital. They don't know what kind of disease it is, whether they're going to live or not. They are anxious. And, we know, as a neurologist, I know that anxiety, fear, sadness can affect your cognition also. Their understanding is decreased by that time. So that is a major barrier in communication. They can be angry, frustrated, not at us, this thing, but generally frustrated. But it can come out on anyone else that why it has happened to me, why this disease, why is my family member dying. There is anger, frustration, generally, I mean, directed at nobody, and that also affects their communication. And then there is this medical jargon, as I said, we keep talking about. This is a video. I hope it has sound. Anyway, it has subtitles too. So this is a movie clip I borrowed from this movie I saw, and there is a patient admitted in the hospital, and I was surprised and a little bit seeing by the things she's saying, because possibly somebody who wrote the script had an experience in a hospital with this atmosphere, heavy atmosphere and heavy words, because what she's saying is exactly what we discuss in these sessions. Appropriately, they have picked the emotions. Then, in addition to that, there is that these patients do not know. There's some messages. Should I stop and check the message?
There are two
The doctor
chat
might.
messages. Yeah.
Yeah, I've opened. Yeah. The
Doctor might be thinking in terms of treatment, and the patient's concerns can be entirely different.
Absolutely. I don't have that slide but today, but that is right on spot, Haripriya, because so this can be a total mismatch. Although both are working for the benefit of the patient, but the doctor is tuned to whether this treatment will work, whether the patient, what are the chances of survival, whether this will happen. And the patients, maybe their expectation may be, what is going to happen in my life? Am I going to be disabled? Will I be able to earn? So yes, absolutely right. The mismatch can be there.
And the communication from beginning onwards can help both the doctor and the patient.
Absolutely. The rapport building should start very early. And that was a particular problem we were having during these COVID pandemic times. These patients were coming in, they were barriered, they were not able to see their healthcare workers behind the PPE. So that was a huge problem. We did these sessions specifically for COVID because it had its additional challenges. There was no rapport building time available. Same thing happens in emergencies. Okay, let's go ahead. So in the end, after all your help, sometimes the patient is not culturally, it happens in many cultures, but I know about our culture where the kids are more trained to listen and obey rather than take their own calls in life. And we always want somebody else to take a decision. And that hampers when we grow up and are not able to take decision when the doctor gives you the options. So, but anyway, that is not their fault or our fault. We are like that. And so what happens when I encounter this? I'm sure many of the medical practitioners here in the session must have experienced this when you give that all the options very well and tell what you want. At the end, they would say, Doctor Saab, jo aapko theek lagta hai kar do, or whatever doctor you feel right, you do. So then, ultimately the ball is in your court. We try as much as possible to involve the patient in the decision making, but sometimes it doesn't happen. And if that happens, how do we deal with it? And so what I do is that if they want to me to, then I'm ready to lead them. I will not tell them that this is one you should be choosing. But then if I feel that what option would I take? And I might tell them, okay, if you can't decide, if I was in your place, I might have chosen option A or option B, and then try to see if they give their consent for the same. I'll skip the cartoon, I think, which is for time. So the question I get asked quite a bit from our residents or even faculty or other people when we do this gym is that where is the time? In our country, so many patients, so much population, and busy institutes like us, PGI, and many other institutions, especially government, are so heavy outpatient that we don't have time for this. We feel it's a luxury. It is. But it is a very important luxury to me. But there is a caveat to it that, again, you can see this research done on this thing, that ultimately, if we addressed emotional issues in the first go, or clearly told the patient, discussed good communication, it actually saves time. You'll ask me how? Because it'll take more time. Yes, initially it will take more time when we are all learning. Once it becomes our nature, it will possibly, it will come automatically. And this time saved is because the patient, you have all experienced, they'll come back or go out, come back, or if not to you, some other doctor or some other hospital. Ultimately time is being lost, multiple consultations, multiple questions, multiple queries. So if we do it in the first go, good communication, it actually might end up saving us time. That is what they showed in this study. Then we have our own issues, as healthcare professionals, especially doctors. We are trained to be heroes, lifesavers. There's so much on giving good news. Hey, operation went well, your patient is fine. We are usually not, things are changing, our medical curriculum is going to change, and our is being incorporated, but mostly till now it was positivity, and we didn't know how to deal with bad news, or how to communicate negative outcomes, or that we felt we have failed if the patient died. So this is something we need to get over as healthcare professionals. What if the patient starts crying? What if the patient gets angry? All these issues can be, to an extent, taken care of if we have good communication. I'll just give you some few examples. That how we do this. This is just a dialogue where the patient says, "Doctor, I'm so worried, I can't sleep properly, and I also have pain in the back." And we'll jump to it. Tell me about the pain, because that is my comfort zone. I'm worried, I can't sleep, I don't want to know what is happening in the patient's life. We can't set it right. They do not expect to set it right, like happens in sometimes, in our friends, close friends, or at home, that we just want to vent our thing or tell somebody, and we don't want you to fix everything, but we are scared that it's a burden on us. So we need to explore a little more when the patient is trying to tell us the non-medical problems. Um, and then we never inquire beyond the physical. Many times, how are you feeling today, or how you have been coping? This usually doesn't come naturally to us. So this is something we can incorporate in our practice. We tend to have leading questions, you know and we all do that. We've all done that. Aaj pain theek hai na? Your pain is better, isn't it? We are basically giving a leading question to the patient, get scared to say no. They say, theek hai, okay, even if they don't have it. Or, do you have pain now? Again, these are a little intimidating questions. The ideal thing to say is, how are you doing today? How is your pain today? Then the patient will tell us clearly. Yes, there are, Haripriya. There are guidelines on communication procedures. I'll be dealing with one or two today, and we have a full session on breaking bad news. On Friday. So I hope you're there. That is an important part of the communication. Thanks. So again, we all care for our patients. This is where the learning comes. Then we have a busy OPD. We want to send the patients home. We have like 10 people standing around. There is no privacy. I've seen in a lot of busy clinics, no privacy. Then you're asking sensitive information from a patient, from a girl, from a lady, or you have to do examination, and then there are 10 other people standing in the room. Sometimes it may not be possible, I know, but as far as possible, we should have in our mind to keep patients' dignity and privacy intact. We keep picking up our phone in between, very common today. Everyone's addicted to mobiles, and that for us may be normal. For the patient, feels that you are not interested in the patient. Big physical barriers may be present, which may be intimidating, and the patient may feel very timid sitting in front of a huge desk. What people propose these days is to have something like this, the lower one, where you are sitting on two corners of a table, and where you can put a hand on the patient's hand if need be, obviously with cultural things in mind, and that is when the communication will become better. So what is the time? 3:26. We have about 15 minutes. I'll briefly go over these very important slides, which are basically form our first lecture in our communication talks, is about the actual communication skills sets. Some of it we have already talked, and I'll just go. We spend, Nilima says, 2.5 minutes on an average with patients in India. How do we incorporate Exactly. That is an important question. This is what I get heard. And I mean, if you know how our center is, we have around, in a neurology clinic, about 1,000 people coming a day. So your point is very well taken, Nilima. The time is limited, and that does have its negative consequence on communication, quality of communication. But as I said, we can try our best to do what we can under the circumstances. And believe me, I started this few years back, and we now, in the same time, in the same patients, I am able to communicate. So everything doesn't take more time. It is the way we do things actually can change. So yes, we may not be able to do the same which if we had half an hour with the patient, or 15 minutes with the patient. If we have 5 minutes with the patient, we can't do all that, but there's a lot we can do. That is the whole idea behind this, is that the way we talk, the empathy, the non-verbals, somebody is written below this, the non-verbal communication is very important. So all this can happen without taking any. Sunil has written that yes, it can be helped. So yes, your point is very valid. But whichever, there are people, I'm sure, in this in our group today who have in a private setup more time. They probably can incorporate everything. We have to do some things which are incorporated in a shorter period of time. I'll just go through the skills, and we'll see some of these may not even need extra time. Just smiling and looking at them in a benign way may be enough. So, okay, coming to skill set one. Thank you for being such a responsive group. That makes it more interesting. So the skill set one is setting up the meeting. So it's like creating rapport quickly. So greeting the patient. Greeting the patient, that takes just fraction of a second. We have the card in front of us. The name is written. Even the father's or mother's name is written on that. All we have to do is make a habit to call the patient by name, and a lot changes with that. Then attend to their comfort. Privacy, I already said. The way they sit. If you already arrange your furniture in a way which is more comfortable for the patient, less dominating, every consultation will not require extra time for that. So there are things we can do without the consultation becoming prolonged. So I talked about phone already. So the second part is elicit list of all concerns. So we have a habit of cutting in. We generally also, when we communicate, even with the patients, the moment start patient half a thing, and then you think that we have understood because we know what is he going to say. Yes, but for them it is not complete. At least let them complete their history once, if possible, and acknowledge it. Then, of course, we have limited time, as you said, and we have to negotiate the agenda. And that is where the time limit comes. So you ask the patient, what is your main problem today? What have you come for today? And this is going to be my focus on this, the next 5 minutes or 10 minutes. You can tell the patient. They will also know that they will not go tangentially on a yarn somewhere else. So that is important. We tell them, if you have 2.5 minutes, you say, I have 2.5 minutes for you. In the next 30 seconds, I will not interrupt you. You tell me what you want to say. And next 1 minute, we will discuss. And then the last minute, we will write the prescription. So we need to tailor it totally to our setting. Then there is history building, attentive and reflective listening. So this is a very important part. You will see all these things are so common to our day-to-day good communication, and listeners, we hear, but we don't listen. So attentive listening means that you actually are listening, giving non-verbal communication. You don't have to say yes, yes. Even just a little nod may help the patient understand that we are listening to their problem. explore perspective, name emotions, which is basically again that impact on their life it is having, how much it is affecting, because our plan may change according to that. Whether this is being a major barrier in their lifestyle, that you might want to be very aggressive in their treatment. And sometimes, in our epilepsy, I keep giving, epilepsy example because that's what I do mostly. To start or not start anti-epileptic treatment is not a written in stone. Sometimes if you have one seizure, young people especially, we don't want to give side effects and see their lifestyle. How is it impacting their lifestyle? Are they doing risky activities? And they might not end up taking anti-epileptic drugs in the end. And somebody with an active lifestyle who has to travel a lot, obviously we would want to control the seizures and they'll be more aggressively managed. So it's important to know how it is impacting their life. Empathy is, how many times you might say this makes the core of our, communication skills. And then we tell them the last part, as I said, now we go to the discussion and sharing information. Of course, after incorporating patient perspective, as we said, I already talked about language, ART loops. So this is what we say, ask, respond, tell. You ask, patient responds, and then you tell. This is something, again, as we said, it is learnable skill. This is what I learned. It used to happen many times. I'm sorry, I'm not reading the points. I'll just read them after this module. So your comments. So teach back, what teach back means. So let's say example, again, I'll give you my example. We say, you have to take this anti-epileptic medication. And आपको ये दवाई खानी है, 3 महीने बाद आना है, come back after 3 months. What I have in mind is that they will take it for 3 months, come back, I will continue it or change the dose. But what happens many times is that they will think that it has to be taken for 3 months. And they will not be able to come at 3 months. They'll come after 6 months. And very commonly, they would have stopped the medication at 3 months. And then you realize, oh. So teach back is you ask them to repeat. Then it will be sure that they have told you that we have to take this medicine continuously. For after 3 months, we have to come. If they are not able to come at 3 months, they should continue another month if they're coming at 4 months. So teaching back is a very important thing, which you come to know that have they actually got what you wanted to. Let me just read the comment. Okay, there's no new comment, right? I think the last thing in today's this thing is about shared decision making. So this is a concept which maybe I have alluded to already, but this is coming more and more because this is something again required. In the old times, it was paternalistic, or you can say my way or highway type of thing, that I feel I am the all-knowing doctor. I tell you, you take this. If somebody doesn't take that, you are angry. You say, go to another doctor, get lost. And you are very upset with that I know better and all, without thinking what is the reason. So that is changing, thankfully. So informed medical decision making is coming in a big way, where we give the information and then we discuss and then we tell them what is best for them. Shared decision making goes one step ahead. It is actually a loop. So after the informed medical decision, what is extra is taking patients' value and preferences. You must have heard a lot about this cancer palliative. You're going to have a talk about end of life care, and palliative care is all about that. Again, patient preferences. I might feel that this patient can be saved. I have learned, I give you chemotherapy and give you radiotherapy, I can save your life. The patient will say, I'm already lived my life, 70s, 80s, whatever, and I want quality of life. I don't want to have side effects, which you have told don't do good to me. I will take symptomatic treatment. I don't want aggressive with a lot of side effects treatment. Now, the perspectives may difference. This is where shared decision gains. Technically, we may be right. We have given good information. Patient, according to us, is making a wrong choice. As of course you're right. You want the patient to live, but that part we have to maturity. We have to show that if the patient is not taking, either permanently doesn't want to take or is not ready, we tell them always, okay, this is what I feel. You can always come back. The golden line being that even if you decide not to take this treatment, you understand that we are still here for you. You come back to us and we can discuss it again. Or if you still don't want to take, we can support you in other ways. This is very, very important. A lot of compassion, generosity, and compromising our ego is required. But this is the way to go in patient management and patient preferences. We say a lot about, Sunil mentioned about smile, and even if you're wearing a mask or a PPE in COVID times, your eyes show that you're smiling. So do smile still if we are behind a mask. Our voice gives away non-verbal cues about that. And a lot of thing about eye contact. Of course, we don't want to stare down a person, but maintaining an intermittent, at least eye contact, and shifting away a little bit to the other point of the face, like I think Dr. Biju had mentioned in this talk. And so these are good things to do, and don't look down while talking. So look straight either into eyes or somewhere, or take a break and look at a side. So maintaining a contact is very important with the patient. Yeah. So last slide. Last slide is again about what we end up doing. Sorry, I was looking for something else. In good faith, but it can have a negative effect. For example, we all found among us or us saying it, don't worry, such a small problem, you'll be fine. Why are you crying? Look at that patient. He has got a tumor which is 4 times bigger than you. No, this is not to be said. We don't want to trivialize the patient issue. For him, that 4 centimeter tumor is equally serious than somebody with a 16 centimeter tumor. So we don't have to compare. Look at the world is so bad. You are still, that is not the time to say that you are lucky. No, they are not lucky that you're not having a 16. They are unlucky to have a 14 centimeter tumor. So what we want to do is, the point here is normalize their emotion. Actually support them. That yes, I can understand you're anxious and worried or crying. Anybody, including me, if in your position, perhaps I will feel this way. So this is how you normalize their emotion, and that is when then they will have a rapport with you and talk to you better, rather than feeling guilty about, feeling bad about their illness. Considering what you're going through, it's normal to feel this way. So normalizing, acknowledging their emotions is more important than giving them false hopes, or, we try to do it for making them feel good, but that may not always work in that situation. I think we'll come to the end. It's almost 3:40, 3:39, and we'll stop here. These are the lot of people who have contributed to developing these things from my side and from Pallium India side. So I acknowledge their help. I'll stop sharing the screen, and let's go on to the next part. Sri Priya, Sunil, is a discussion.
Yeah.
If somebody wants
Yeah.
to put in a question.
Thank you.
Yeah.
Thank you, Dr. Parampreet. If you have any comments or any questions, please do that. Please unmute yourself and speak. Or if there are somebody else who cannot speak because of poor bandwidth, please type your question in the chat box.
So there were people talking about time limitations. Yeah, carry on, please.
Anybody?
just going through the chat if I missed anything which can.
Okay, there is one question
Yeah.
from Dr. Kanmani. How can we tackle angry patient attendance while declaring death?
Okay.
Yeah,
That,
we will deal with this in the next class, but I think Dr. Param, you can just touch
yeah,
on it.
we can touch upon it because you know uh, uh, mostly we'll be dealing with breaking bad news. That in itself a very important topic. So we can talk a little bit about angry situations, and I'm sure we all know that angry situations are increasing in our setup. So first we need to understand why we are having these angry situations more than before. Um, so one important question thing, according to what I think, is that healthcare is becoming very expensive. We do not have universal, the government is getting into the insurance and schemes and something, but still a lot of people pay out of pocket. And that is where, people are not very rich, and it's expensive treatment procedures. And that is where the anger comes from. It may not be totally, it can be directed because they feel somebody's been negligent or somebody's been this thing, but a large part of it may be due to, as I said, poor communication and the patient's frustration that so much money has gone and nothing could happen. They have probably sold their property or house, and then the patient still goes. So we need to understand the importance of understanding the anger, why it is coming, is because it may be just a sign of distress rather than somebody trying to harm you or harm us. So if we know that, we'll respond in a different way. We won't jump back on the patient. So there are a few points. I don't have the slide ready. Probably I'll show you in the next Friday talk. But what we tell our doctors is that, one, if there is, you feel this situation is going to turn a little, nasty, your security is very important. So every hospital should have security guards. You, before talking to the patient, or when the patient starts talking or attendant getting angry, call up somebody that you are not in a secluded area. Try to be in a busy area where there is something. Then if there is a small barrier, at least arm's length, that somebody can't just jump on you. It's good to discuss these things at least, like we say, the proverbial arm's length from one another. Once that is done, then we don't stand dominating. Better to sit, but if not possible, stand in a little bent position, which is a non-offensive position, considered non-offensive, and listen. Most important is listen. Let the patient or attendant say it. We don't have to accept that all the mistakes they are saying we've made. We don't have to say that, but we don't have to always feel sorry for wrongs done. We can even feel sorry without our wrong being done, that the outcome was not good. So we can say things like, I am so sorry that this happened. I'm really I don't have words to say that what you must be feeling now. So if you have something, say it out. This would disarm people. Showing compassion and being ready, or lowering your ego, half 50% work is done. So this is what we want to do, is then let them talk, let them finish, let them come out with whatever angry words or sometimes bad words they have to say about the hospital or us. Just let them finish. They are the ones who's harmed. We have to be some who do not reciprocate. After that, once it is done, we choose from there. We accept the ones which are correct, and we say, okay, I'm sure you feel that way, but this is the facts, what had happened. Try to get to a common ground. If there is something correctable, everything is not in the past, we can do that. Is not getting a bed, patient is worried, that can also get anger. Anger is not only if the patient has died or something. They can be about things which are not happening and can happen. So if we have something we can do, we do that. And the last thing which we say is that, just saying that if you are not satisfied, there is this, every hospital has a complaint book. You can actually, I'll tell you where it is. You go and write your complaint. So, see, it looks counterintuitive that I tell them to give a complaint against me. They will give a complaint. What will happen? But in reality, many times when you show your willingness to accept and do the right thing, patients actually get less, intent to file a complaint. So we at that time we behave as their advocates rather than our own advocates, and this is how this thing. Of course, if it gets too bad, you have to save yourself, and as I said, get the security, have somebody on standby if it is getting physically violent. So this is what, in brief, what we try to do in an angry situation.
So, Priya is asking, can we withhold the information regarding a disease from a patient at the request of a caregiver?
I'll come to that. Who asked that?
Dr. Haripriya.
Dr. Haripriya, this is one of the important things which is going to be discussed about in the Breaking Bad News. But I'm happy to talk if we have, since we have time today, before the case is presented. I can give it briefly. Maybe we can discuss other things which you think of in communication on Friday. So it is a dicey topic in our culture. So these are again cultural issues where in many cultures I have worked outside the country, and it will be considered shocking if you don't tell each and every fact to the patient. I mean, how can you hide? Even in fact, you should know that medically and legally we are required to communicate. So this is the thing. But yes, culturally it does come in, and every day it comes in. We have not told our father, unka dil kamzor hai, he won't be able to bear it, don't tell this to them. So there is research to show, number one, that it is not like that. Many people would rather know about their, I'm talking about Indian research. Again, because this was not a topic, I don't have the slide. So they did, and a lot of people actually wanted to know day to day, but there are some people. So what do I do in that case? Ideal thing may or may not happen is try to know the patient's will. Hiding against patient's will become almost like an offense. So as far as possible, what we try to do is, before I have the information or the negative diagnosis, in your cases, maybe sometimes you're doing a FNAC or a biopsy and you don't know the report. I see a patient may having a life-threatening disease like a motor neuron, but we have not done the electrophysiology. This question should come that time. So what we try to do is, or what I try to do is, that I ask the patient, if I suspect a chronic or a life-threatening illness, that if I don't know what is wrong with you, if something is, reports are come, who do you want, how much you want to know? Do you want to know everything, or do you have somebody else I should be talking to? And you'll get different answers. Some people will say, oh, tell me the mota, lest you tell my son is here, or I don't want to hear, I'm just old, let talk to my family. Or somebody might say, oh, I want to know everything. There are a lot of people, because we don't realize people have to make decisions for their life. Somebody has to write a will. If they don't know they are going to die, they might not write a will, and it may be detrimental to what they actually wanted to do in their life. So the default position should be, yes, obviously we'll talk about how to make the impact less shocking to them, but ideally in them we should try. If you don't have a choice, then I think, I don't know, we have to have our own hospital rules, that if some attendant comes and doesn't even get the patient and tells that I'm so then we what I usually do is that I have to talk to the patient once. I mean, of course, generally they can read what is going to happen, and ask the patient's consent not to tell what is wrong, to ask them who should I be talking to. So this is the ideal thing. We should try to practice as much as possible, even when the family says that don't tell my so and so, they will not be able to take it. If you have a chance to meet the patient, we talk to them that we have to discuss all your prognosis and disease and treatment. Who is it you want to know? If the patient says, tell me, again, we can ask them, how much you want to, do you want to know everything, the good and bad and everything? And then we take it from there. So this is my approach usually to this problem where it comes that don't tell the patient. Okay, if the patient doesn't want to know, why should I tell the patient? Then he has nominated somebody, or she has nominated, tell my husband, tell my wife. So I hope it answers to an extent, but I can understand this is a very tricky situation and we may not always have the ideal case in this.
Yeah, I just want to add to this. If some of the caregivers ask you not to talk about the disease, we should understand that the caregiver is very anxious, that you are going to deliver the bad news to my loved one, and you are going to cause hurt to him. Why the caregiver is so much anxious? They want to protect their loved one from us, the medical professionals. So it is an act of love. That's what we have to basically understand. We have to actually empathize with him, with the caregiver, telling that, okay, you are so much worried that we are going to give the information to your loved one, isn't it? That itself will give the caregiver a message that we care for the care for not only for the patient but also for the caregiver. And then the next step would be to find out or to explore why the caregiver is telling like that. Can you tell me uh, why you don't want to communicate? Or even before that, you may some people may even tell that, okay, I agree with you that we will not communicate the news now. Or some people will say that, okay, you want to do good for your uh, the loved one. We also want to do good for your loved one. So let's work together um, to come across this situation. And then you explore the points why they do not want to uh, disclose the diagnosis. So there will be many points, and the next thing would be then you will ask the caregiver, is there any advantage for of delivering the bad news? So there are some advantages of delivering bad news, and after this, you will tell the caregiver that how you are going to communicate this bad news to the patient. And after this, you will ask, what do you think now, to the caregiver? And the caregiver may sometime agree with you, or he will tell you, I need to discuss it with my brother, sister, etc. I need time. So these are all outcomes of this discussion. And sometimes they may agree, and you may even go and tell the patient. So this is in short how you deal with such situations.
Absolutely, makes sense. Yeah, thank you, Sunil. So
There
we
is
is
another comment from
yeah.
Dr. Girija. She says she had a patient today in her OPD who defaulted chemotherapy. So she's asking and came with an advanced disease after the default of chemotherapy. So how can we manage that? What to tell what to tell to such patients? Uh, so that was her question.
Okay, yeah. So this is something related to what we talked about. That was that in spite of our best efforts, the patient did not take. They defaulted. So the immediate reaction is to tell them, why you come, you're wasting your time and my time. That is the doctor's usual reaction to it. Sometimes we say it, sometimes we feel it, but that is what we want to move away from. We understand, we try to know why the patient did it. Maybe there was some lack in communication and something. If it even if it wasn't, it could be totally patient's own decision without any of our contribution to it. So the simple answer to that is that start with a clean slate. Tell them that well, one can tell them, because you don't want them to default again, that this is what has happened, that if once you stopped, your disease has increased, and this is the factual answer has to be given, and I'm still there for you, but it all is not lost. And this is where we can start from. And if you are wanting to start again, the protocol will be changed now, and we do this. So we just take it as a professional matter of fact thing, rather than trying to get into a judgmentalism or a emotional discussion with the patient. We just have to behave like professionals, as if the patient has come today with that kind of advanced disease, and you start again. And even if the patient says, no, I didn't come for that, I just came for a follow-up to know where I am, and I'm not anyway planning to take. Happens many times, that I don't think happens more in the Western culture than our cultures, where people take a lot of those kind of decisions. But still, there are people coming now for whom quality matters more. So no, I just didn't want to take. And again, it is important. Somebody said calm, so maintain our calmness. Okay, so this is it. Maybe if you come again after 2 months, this would be even worse. But this is what I recommend, and then you take a call on it. But you must understand the price to pay for your decision. So this is what I usually would want to do in that circumstance. Somebody asked about documentation. It is important to document. Better the documentation, more comprehensive documentation, whether or not it is going to get into a litigation or anything, but still should be a habit to document. If the patient refuses treatment, it is always good to document that goes without saying. Good documentation helps in the long term. How do we have 2 minutes before the case starts. How do we counsel the patients who gets multiple opinions from different doctors? How do we communicate with such patients? So, yeah, again, important and very relevant. So we have to understand that medicine is not a rocket science, and and that's what we have to convey to our patients also. And it is true. Many times a doctor's perspective may differ from the other doctor. So rather than trying to put yourself one up on the other person, yes, if you don't agree with that, we have to be very honest. This is not what I would do in your case. This is my plan, rather than trying to over comment or under comment. Both are not good. If you want to say, no, somebody's written, I should not say. Maybe there's a way to say it without, knowing why that doctor took that. You don't know. The doctor's not there. They've taken multiple places. You say multiple places, people may have different opinions. For me, I am very clear. I would probably not choose this. I would do that. I will give you my options. You do that. So yes, it is getting confusing. And one of the doctors is, internet these days. They have read a lot from the internet before coming. So it is getting a little difficult to do, but we are learning also. Getting away from only mine is right. People have sometimes very valid questions which are uncomfortable for us, difficult for us. So that is what we have to learn today. Sometimes somebody will come with the knowledge which I have not read in the last few months. There is no harm. I tell them, I do. I'm telling that I don't have that answer right now. I have not seen this kind of patient before that, or some new drug. Nobody has brought that. Maybe it's available to your family in America. It's not available here, but I will read about it. Next time you come, I will have that information. No harm in that. Sometimes we get a bit defensive. So if they have come with multiple opinions and some knowledge, which today is not in our RAM today, we can always openly say, well, this is what I usually do. What your point is saying, I don't have a comment on it. I'll have to check that out. So what? We are humans. I think it's time to go to the next step.
I think we will move on to the patient story. Supriya, can we move on to patient story? Yeah, and Dr. Pratiksha Agarwal will be presenting the patient story. Dr. Pratiksha?
Yes, sir. Hello, good afternoon to all. Hello? Okay.
Yeah, we can hear you. Please continue.
Okay, sir, thank you. My patient is a 23-year-old female. The diagnosis was she's a case of incomplete abortion in an operated case of acute pancreatitis. Now, the patient presented to us with complaint of abdominal pain for just 1 day in the hypogastrium, which was insidious but spasmodic in nature. Now she has history of bleeding per vaginum early in the same day morning with passage of clots, and the patient tested to be UPT positive. In the history of illness, the complaint started just 20 days back when the patient developed acute abdominal pain in the right hypogastric region and the epigastrium, spasmodic in nature. On investigation, she was diagnosed with acute pancreatitis, and the surgeons planned for pancreatectomy with resection and anastomosis of the small bowel. She was in the ICU, where 5 to 6 days later, again she developed some dull aching pain in the abdomen. The inflammation was not subsiding, and they had to go for again an emergency exploratory laparotomy, wherein adhesiolysis was done. Then again, she was shifted in the surgical ICU under observation. But today morning, when she passed blood clots per vaginum, she was then referred to the obs and gynae department. On USG examination, hemoperitoneum was seen. So once again, they decided to explore, and an exploratory laparotomy was done. Hemostasis was achieved. No exact pathology could be diagnosed. It was just oozing in the abdomen. Uterus and the fallopian tubes were ruled out for any abnormalities. On examination, the patient is conscious oriented, but she is poorly built with poor nourishment. Patient has tachycardia with a pulse rate of 126 per minute and the hypertensive with a blood pressure of 80 by 40 millimeters of mercury. Saturation is 98% on room air, and she is severely pale. On per abdominal examination, there's tenderness over the incision site, and rest all the systems were normal. On examination, investigations, the hemoglobin was 8.5 and platelet count was normal, 138,000. Total count 13,800. Electrolytes were within the normal range. Serum potassium was 4.2, creat was 1.2, and USG abdomen showed hemoperitoneum. Now, the psychosocial aspects was, we here have a young female who's just 23 years old, married 1 year back. She was recently diagnosed to be pregnant, which was definitely a very happy news. She was absolutely all right 20 days back, suddenly developed abdominal pain, and now she is on ventilator with inotropic support over a short span of 20 days. On medication, she is receiving high antibiotics, analgesics. Blood pressure is maintained with noradrenaline infusion, titrated according to response. She's receiving total parenteral nutrition and multivitamins. Now, our main concern is definitely to achieve hemodynamic stability and wean the patient off the ventilator. But even after recovery, we have to encourage the patient to get over her loss of pregnancy and to keep a positive attitude. Explaining to the family how everything that was going fine has suddenly turned so disastrous. We have to explain the family about her condition and also help the family overcome the dual shock of losing the unborn baby and also the critical condition of the patient. So I would summarize my case. We have a 23-year-old female patient with acute pancreatitis who is UPT positive. Pancreatectomy was done with resection and anastomosis of the small bowel. 5 days later, exploratory laparotomy with adhesiolysis was done for bowel obstruction. 15 days later, she had incomplete abortion and she went into shock. Patient was resuscitated, kept on ventilator under volume control mode with noradrenaline support. So discussion points would be, the family is receiving bad news one after the other. So how should these be communicated? And again, once the patient is discharged after critical illness is cured, how should the patient be counseled for everything that has happened to her? The duration of illness is very short. So what kind of palliative care should be administered in this case? And definitely this is not a terminal illness. So what all kind of palliative care will be applicable in this situation?
Yeah, thanks,
Oh.
Dr. Pratiksha. Yeah,
Thank you,
it's an
sir.
interesting case. I think we would ask some of the participants to frame the issues, like, in a case, lawyers frame issues. So what we like to do in communication discussion cases are that frame what she has already framed the issues, but you can always unmute yourself. What are the issues at stake here? Breaking bad news is one. What is the other things which out of the communication domain which are relevant here? So does anyone want to comment on it? Yeah, facing an unexpected or rare complication, totally, as Dr. Pratiksha mentioned, that it just came out of the blue. I mean, many things come out of the blue, but this was like a newly married, pregnant, expecting a child, and suddenly it's a downhill course. So it is very, very difficult. So it is a expectation. So that is one. Yes, one, of course, consent issues also. So yeah, so informed consent makes a very important part of communication, and very, very important. You have seen that there's a long consent forms being made these days, but I'm sure you've also seen that sometimes what happens is those are not really done. So this is for good of all of us that they're actually done. It is not that there is a long consent form, and I'm sure you're familiar with this situation, and outside the OT, the technical staff or the nurse or maybe the junior doctor comes and says, I don't know how much of you understand Hindi, that Babaji sign kar do, just sign over it. This is very, very common. This is what we are trying to discourage, and this sign is not going to save us if something goes wrong. So when we say informed consent, it has to be informed properly, no doubt. I mean, there are different levels in different situations, and different, how has to be documented. Every hospital, every society has their own these things. But what is definitely not to be done is that after writing all that long thing, you just tell them to sign and just get the sign on it. So that is very important. Consent is one important thing where you have an adverse outcome. Very important to give good consent is basically communication prior to the thing is done. And what else? Naveen says the question will rise whether this could have been prevented or picked up earlier. Would that have changed outcome, reduced morbidity? Yes, these are all relevant. We may not be able to discuss in detail the technical issues here because our focus is on, you're right, medically there'll be a lot of, so that goes more into the domain of medical audit, it is an internal hospital audit or team audit or something, that what could have been done. We have these audits in our hospital, but we are focusing today more on the communication part of the thing. So yes, audit is very important, but let's have more communication issues. I would just put in my thing here, maybe Sunil and Supriya can also chip in. Grief will be a big issue here. So the case what Dr. Agarwal is presenting here is not about acute thing about getting better. It's about a long-term grief. And Elizabeth Kubler, you may have heard those stages of grief. At some point, we do discuss. I don't know whether we'll be able to discuss in the sad news. I'll try to do that. So there are different ways people cope with grief of that kind. And another issue is empathy and trying to get into the patient's shoes. Now, there is, I had a discussion somewhere, somebody lost a baby like this in about first or second trimester, and someone made a comment that, okay, but the baby wasn't born, and there was no connection with the baby. And, why, okay, people should get over it easily. And then during that time, as I had some experience, somebody known to me, they were having a Holter monitoring done, or some other monitoring Holter. So they had a machine on them, and somehow when they came home, they pulled the wire mistakenly, and it did not record for 24 hours. They had a machine hanging. They were very careful, and when went there, the patient had accidentally pulled the wire out, and it did not record. It switched off these things, and they were extremely upset about it. That 24 hours, I didn't do this, I didn't do this, and also imagine the plight or the mind state of a woman who has carried that baby in her for months, and this thing. So these things you can't imagine unless we have empathy, compassion, and try to be in the shoes. So there'll be a lot of communication issues in this, according to me. Grief will be one, depression may come, communication will come, bad news will come. Of course, medical issues will come later too, whether we could have done a better job in any case, but that is a different issue altogether. Counseling from doctors, counseling from social worker, counseling from psychologist, or even psychiatrist, if it is required, needs to be done. And that issue of not trivializing, not trying to make the patient, nothing has happened, you'll be fine, things happen, see, you'll have another child soon. That is different. That is to be done by a very, very professional person, not us. The treating team, they don't want to listen this from the treating team. So we have to be very clear. This has to be said at some point of time when that acute phase is over. But not at the time when the patient is getting bad news. That is time to them. Just show empathy, just be there, just to hold their hand, listen to them, just quietly sit around time. So this is we have to differentiate. The timing of our response has to be very important. Anybody else, Dr. Pratiksha, or anybody else wants to make a comment on this?
Does this patient know that she is pregnant?
Yes, sir. The patient knew that she was pregnant, and she was also explained the risk of anesthesia, that this could lead to the loss. But however, explaining it that this could happen and that actually happening was a bit, that is something that needs to be communicated. She was explained at the time of consent, the family was explained that anesthesia has its own risk and it could lead to loss of pregnancy.
So why did she require surgery for acute pancreatitis?
Well, so that was the surgeon's decision, I think.
Probably necrosis of pancreas can become
Yes, they
life-threatening.
had to do a small bowel resection.
Yeah.
So they said it was a life-saving surgery at that moment. So they had to do a small bowel resection at that time.
I actually don't know much about that, but I think that could be the reason, is that if the necrosis and it is a life-threatening for the mother, of course, you have to save the life, of if the mother doesn't survive, the baby wouldn't anyway survive.
Okay, so I think the critical thing was in this patient was, as somebody has pointed out, did we take a good consent? So was she informed about what surgery is being done and what are the risks involved, and with a clear indication that this miscarriage can happen. From what you have presented, I understand that this has been communicated very clearly, and an informed consent, I think it will also have taken. But what was the our how many months since she was pregnant?
So she had a history of 2 months of amenorrhea.
Okay. So as Dr. Param told, one of the issues that she's going to face would be the grief reaction. So there are 5 stages of grief, which Elizabeth Kubler-Ross has described. That is denial, anger, bargaining, um, depression, and acceptance. So these stages may not occur in all patients in the order, but some patients will directly come to acceptance, but some patients will go through various stages, and sometimes they may not reach at acceptance at all. So this is a complicated thing because she has been carrying for 2 months, and maybe she was in the preparation to become a mother. So that might cause more distress to her rather than the pancreatic surgery. So it is important to talk to her and inform her what has happened, and listen to her what she want to tell us. So I think listening to her and understanding her concerns regarding the things what has happened is very important. Um, and maybe the social worker or a team of multidisciplinary team would help, even if she goes after discharge to the home. I think proper follow-up is needed because she may have many doubts. So probably I think from a palliative care point of view, I think even if this patient does not strictly under palliative care, but um, she has a lot of psychology, or she will be facing a lot of psychological suffering. So even spiritual suffering. So I think these are the principles which we need to integrate into the care of this patient. So supporting her through this difficult time, which I think will not be able to do by other specialties. Or if you are willing to support this patient, proper follow-up and even phone calls whenever the patient wants to talk. I think it is very necessary so that she has somebody to speak whenever she want to. So I think those are the palliative care principles that need to be applied here.
Yeah, I agree totally. And very important point what you mentioned was the continuity of care. So in her case, it won't be a cross section in one go. It has to be a continuous, and it has to be handed over to the relevant people, psychologists, psychiatrists, and as Sunil mentioned, depending upon her belief system, whether it's spiritual or religious, people fall upon different coping mechanisms. So whatever her belief system is, that can be brought into play in this, and for her seeking a bit of comfort.
I would like to stress the point that Dr. Param just now told. It is important to find out the coping mechanism of the patient. So she might have gone through some difficult situation in her life previously also. So it is important to ask her, how have you gone through that difficult situation? What all helped you in that difficult situation? So those are the points that we need to reinforce, that and that is going to help her.
Dr. Pratiksha, did you have anything in mind regarding the palliative or communication which we haven't talked about?
Hello.
Yeah.
Yes, sir. Yes, sir. I totally agree that we do need to give a continuous support to this patient. Definitely communicating right now, and then she needs regular follow-up. and also good counseling in each sitting so that we can know about the issues that she's facing. We will have to take care she does not go into depression or similar symptoms. So she will definitely need counseling for a bit long time, I think.
Okay. Anybody else has any more points to raise or any comments? I think it is also important to call for a family meeting and understand their insight regarding what has happened and fill in the gaps that they have that they do not know, so that all the family members know what has happened, and even you can tell the family members that she needs good psychological support, uh, so that they will be giving more attention to the patient.
Absolutely. You know, one thing sometimes we may not think much about is the regularity of the briefings done. So once we tell, things do change, especially in such a dynamic scenario like this patient. The prognosis changes, the treatment changes. So this is a good idea to have what do you call this, family meetings, as we call them, on a regular basis. Like after every round, you call the attendants and talk to them, not once a week, or not, it can happen more than once a day also if the situation has changed. So regular briefing, like we have, once there are these disasters or COVID, we all saw some leaders stepping up and giving regular briefing to their citizens of that state or district. So that is also very important in us, is that we make it a habit to give regular briefing to people and update on the latest what is happening. So if the situation has changed.
Yeah, Dr. Jaya says answer their questions with empathy, which is very important. So whenever we talk to anybody, empathizing with them is a mean to communicate that we care for them.
Choose kindness over correctness. So they may ask questions which might look weird to us or silly to us, but then we have to understand where they're coming from. They are not, you go to there, if somebody is a professional or somebody is an artist, if they are on stage, they are very different there. Now they're in the hospital. So don't think those people are dumb. They are in a situation where their cognition is impaired. So that is where they are not in their comfort zone. We are.
Anybody else has any more points? Okay, so I think we will end here. Thank you, Dr. Param, for taking us through the basics of communication. I would also like to thank Dr. Pradeep Shah, who presented a patient story from a different perspective, which had issues of communication. Once again, thank you, Dr. Param, for finding out time for this session.
No, my pleasure.
Thank you.
Very
It's over
much.
to Sri
It's
Priya.
been a good discussion. Thank you so much.
Thank you, sir. Thank you, sir.
Thank you, Dr. Parampreet. I personally know that I have been troubling you since morning with lots of WhatsApp messages because it was a last minute communication from my end. Sorry for that. And thank you so much for making this session very interactive. And I believe that this would definitely have been an eye-opener for at least some of us. And looking forward for your next session as well, which will be as interactive like this. So with that positive note, this is Sri Priya along with Dr. Sunil Kumar and Dr. Parampreet signing off from the Tips Eco Hub. See you in the next session. Till then, everyone take care. Be happy. Bye-bye.
Thank you, Sri Priya.